Yeah, good stuff. And anything else to say here?
The joint line appears to be intact all the way across, so it's the same size all the way across.
Yeah.
So there's no tailor shift.
Good, good. So we will cover the tailor shift. So that's fantastic. So I will now need a second volunteer, please. So turn your camera on and unmute your mic, please. Remember, we've got to finish this by 8 o'clock. So the quicker I get a volunteer, the better. Otherwise, I'll start asking people, and then it becomes a bit uncomfortable. Finally, have a go at the one in the middle, please.
Okay, so it's an AP X-ray of a right ankle, and I'm looking at probably a transverse fracture of the distal fibula of the lateral malleolus at the level of the syndesmosis.
Right, good. Alex, just to question you, what makes you think this is transverse and not oblique or spiral?
No, I meant oblique, but I can't quite tell whether it would be oblique or spiral.
Yeah, so that's difficult. And I saw that question pop up in the chat section. Really, it's quite difficult to tell whether it's oblique or spiral. The only way you can tell the difference is if you can see an apex, which is this part of the fracture, and you can actually see like a squiggly line going through like that. And even despite that, there still remains a controversy whether it's a spiral or an oblique. It's pretty difficult in reality to really ever get a pure oblique fracture. Majority tend to be spiral, which is due to the bending moment around the fracture site. So, my view is it really doesn't matter which one it is, just offer both. So it's either an oblique or spiral. Okay, and I think the rest of the description is really good. I would cut out the word probably because you're perfectly right. It is an oblique or a spiral fracture of the distal fibula, and it's clearly displaced. When we're talking displacement for extra marks, you can talk about which way the distal fragment is displaced. Okay, so this is displaced laterally. So always talk about where the distal fragment is in relation to the proximal. So this is translated laterally, and it looks slightly shortened as this spike should be there. So that's really for the extra marks. And I think you mentioned that it's at the level of the syndesmosis. I'm going to go through what the syndesmosis is. But yeah, well done. Thank you.
Thank you.
And then the last volunteer for this bit.
Can I ask a question about the last one?
Yeah, the one in the middle, yeah.
Yeah, can you explain what you're referring to for the displacement, where the displacement's referred to it being displaced
fine.
from?
Yeah, that's a good question. So let's look at the first one, okay? So there's just a pure fracture line here, okay? We can all look at that. If you've got a good resolution screen, you'll be able to see there's a fracture here. And this fracture is what the general population will refer to as a hairline fracture, where you can see the fracture line, but the bone where it's supposed to sit is still sitting there, okay? Whereas in the second X-ray, the one in the middle, you can see that this bit of the bone should be sitting right underneath it. It shouldn't have moved left or right, medial or lateral. So the fact that it has moved one way or the other, it means that the fracture, which used to be undisplaced if it was held together by soft tissue structures, has displaced already. Okay, so that would have happened at the time of the injury. So that means, this fragment of bone where it's supposed to sit is no longer sitting where it should be sitting. Is that clear?
Yeah, no, I was just wondering, when you're saying medially, it's just...
Okay, so medially and lateral.
Sorry.
Yes, so by medial and lateral, I mean, that's the medial malleolus, that's the lateral malleolus, right? So whenever we talk about displacement of a fracture, we always use the proximal fragment as the reference point, and we always talk about the direction of the displacement based on which way the distal fragment is going. Okay, so given that this is lateral, because your fibula is the most lateral bone, the distal fragment, which is the fragment that's away from the joint, the most distal part, has actually moved on the lateral aspect. Okay, it's moved that way. So this entire thing has moved in that direction. So this is why it's a laterally displaced or laterally translated fracture. Is that clear?
Yeah, no, that's clear. Thanks.
Okay, good. And any more volunteers for the last one?
I'll give it a go.
Thank you very much. And who are you? Is that Haseeb? Yeah.
Yeah,
Okay.
see.
Right. Okay. Go for it.
I think this is an AP X-ray of the left ankle joint. There appears to be a fracture on the distal third of the lateral of the fibula, and it appears to be I forgot the term that you used, but I think it's comminuted fracture.
Why do you think it's comminuted? Just out of interest.
I feel like both of the joint lines aren't continuous, and it's not like one clean sort of cut. I see it going down, and then I'm not sure. I don't see like a clean cut through the bone.
Oh, I
like
see.
up and
Okay,
down type
fine.
thing.
Okay, fine. All right. Anything else you'd like to say?
The ankle joint appears to be non-displaced, and the joint line seems the same. I'm not sure what else.
Well, just to ask you a question, do you think this gap here, can you see my mouse cursor?
Yeah.
So do you think the space between the talus and the medial tibia, is that the same as the space between here and here?
No, I think there's some talar displacement.
Yeah, I think so, and we'll go through that in some detail just shortly. But essentially, yes, you're right. So you've got a distal fibular fracture. Okay, those of you that know what syndesmosis is will say it's above the level of the syndesmosis. Syndesmosis is somewhere around here, and it is minimally displaced. I can't see significant displacement. Most of the bone is fairly congruent throughout. And last but not least, we talked about this being some talar shift. Okay, but yeah, well done, Haseeb. Thank you for volunteering. So this whole concept of the talar shift and the syndesmosis is all to do with the ligaments of the ankle. So your ankle joint, essentially from at the front and the back, is encircled by quite close capsular ligaments that keep the ankle stable. So this is the front of the ankle, and between the tibia and the fibula, there's a anterior inferior tibiofibular ligament and something similar at the back. Okay, so whenever you get a fracture, if you get a fracture below the level of syndesmosis, which is essentially, if you look at the previous slide, is this space between the tip of the articulation between the tibia and the fibula and the most distal part. So that's in that entire area would be the syndesmosis. So it's not just one line, it's essentially a continuous space, which is at least 2-3 centimeters. Okay, so if your fracture is below the level of the syndesmosis, that's like having really bad ankle sprain. If the ankle joint's at the level of the syndesmosis, then that could be good news or bad news. Okay, but good news is if you've got no talar shift to go with it, that's good news. That means although there's a broken bone, the ligaments have held. And if you've got an ankle fracture that's above the level of the syndesmosis, then essentially you're more likely than not, pretty much 100%, that you would have disrupted your syndesmosis. And that was essentially the reason why the Weber classification was made, which those of you that are in final year will know about, and those of you, essentially our third year or fourth years may not know. So Weber classified the severity of these injuries based on the relationship between the fracture and the syndesmosis, syndesmosis being between this space and this space. So we can see Weber is below the level of syndesmosis, which is really not big of a deal. One at the level of syndesmosis and one above the level of syndesmosis. Okay, and as we can see in the previous image or slide, this is your Weber A, and the syndesmosis, the ankle joint seems to be okay. No evidence of shift of the talus, and the joint space between here and there is congruent throughout. This is a Weber B, it's at the level of the syndesmosis. Again, the joint otherwise looks okay, and there's no evidence of shift of the talus. Whilst the C, that although the fracture doesn't look particularly serious, is pretty much an undisplaced fracture really here. And despite that, the talus has shifted laterally in relation to the tibia sitting above it. So those are the ones that require surgical fixation without any doubt. Okay, so just a few more volunteers now. I think now, given that we've gone through things a few times, I think it should become second nature to you guys if I've been able to teach you anything that's relevant at all. So one volunteer, we talk about Jason Humphreys, and then we move on to the next one and the next one, and then the next joint.
I just ask a quick question about the Weber classification. It's Tina.
Yeah.
Does it have to include a medial malleolar fracture, or is that irrelevant?
Right, so the Weber classification, that's a shortcoming of it. It only really talks about the fibula.
Grand.
Okay, so the medial malleolus becomes a whole different kettle of fish.
Okay.
Generally speaking, if you've got a medial and a lateral malleolar fracture, they generally tend to be unstable anyway.
Okay.
So in that case, you don't really then talk about Weber classification, unless you're on the phone to somebody and you're trying to say, well, the fibula fracture is below the level of syndesmosis, but they're also a medial malleolar fracture, like here. Okay?
Thank you.
Good. So back to a volunteer, please. And if nobody wants to volunteer, it's going to end up being the same people who are getting the most out of this session. And I don't mind having them as volunteers again.
I don't mind having a go.
Yeah, please, go for it.
So AP view of the right ankle joint.
Mhm.
I can see that there's a transverse fracture of the distal fibula with some lateral displacement.
Yeah, fantastic. And what about this stuff?
Oh, that's patient identifying details that you start off with Jason Humphreys being 20 years
Good.
old.
So if the patient identifying details are there in an exam situation, and you can easily be asked to talk about an X-ray, and these are just, they are what we call 3 points. And if you don't take the 3 points, it's just a shame, but your diagnosis is perfect. And would you say it's above the level of syndesmosis or below?
Below.
And would you say it's a Weber A, B, or C?
I can't remember, sorry.
So A is the good one, B is bad.
Oh, so
and
A?
C is really bad.
A?
Yeah, it's A. Fantastic. Right, good. So nothing else to say here. Next volunteer, please.
Yeah, I can go.
Go for it.
So this is a AP of is it the left ankle?
It is the left ankle, and that's because
Yeah.
the fibula is on the most lateral
Um,
part. Yeah. And I'm sorry, I don't have a lateral view for you.
Okay, and I think it's a fracture in the distal. Is it the distal third of the fibula?
Yeah, it is. Yeah.
And an impacted fracture
That's perfect. It is actually impacted. I'm glad somebody said it. Yes.
that is Weber classification C.
Yeah. And what do you think is happening to the talus?
Oh, and there's. Oh, I forgot. Sorry, I forgot what it's called. Talus, like dislocation.
Talus
not
shift is good.
Shift.
Yeah.
Sorry.
Yeah, no, that's good. That's good. I have once had the description called talus swift on an A&E document. So if you're ever in doubt, think about talus swift and make it a shift. And what about the patient?
They're 20 years
Yeah.
old.
Yeah, so just again, you're missing 3 points. You've got to say the name. Choose one. In 20 years old, taken on this date, is a skeletally mature patient. Okay? So
Okay.
just don't give away the 3 points.
Yeah.
Okay, perfect. Okay, so this is a difficult one. Anybody who's brave enough to give it a go, they will win my highest praise. Right, anybody that's had a go before can basically improve on their skill. Go for it.
Above the
But I have a go, and Alex can join me.
Yeah, go for
Kind
it.
of looked at it before. So this
Yeah.
is an AP and lateral of Alfie Selman, a 12-year-old, taken on the 14th of November 2021.
Yeah.
It's an AP and lateral of his left ankle, and it is a skeletally immature X-ray.
Why did you say it's a skeletally immature?
This is where I get confused with these words of the. Hang on, give me a minute.
Or if you were to just make a very sort of
Because of the growth plate, I can still see
yeah,
the growth
exactly.
plate.
So this is the
Epiphysis
growth
or
plate,
something.
yeah. So
Yeah.
if in doubt and you can't come up with fancy scientific terminology, just call them what they are. So it's a growth plate. Fantastic. Carry on.
Alex. So there is a transverse fracture to the. What is the bit that's below the growth plate? Is it the
Epiphysis or something.
epiphysis.
Yeah. So it's the epiphysis, yeah.
and it extends into the growth plate, and then it will obviously exit through. So it
Yeah.
involves the growth plate as well.
Yeah. Would you say it's transverse, because this is transverse?
What's the other word? That if it isn't, but I want to say vertical, but I don't feel like that's
Oblique.
a word.
Oblique, yeah.
Oblique. Okay.
Okay, good. Fantastic. Right. There's nothing else to say on that. So it's a displaced intra-articular distal third tibia fracture with in a 12-year-old who's skeletally immature. And yes, this is the physis, which is a growth plate. It's not a fracture. Epiphysis, which is the
Not a fracture.
bit that's closest to the
plate.
joint, and metaphysis is away from the joint. And then you've got the diaphysis, which is where these bones are. Okay, so just to cover that, for
Not
those of
a
you that
fracture,
don't know
growth
that
plate.
well, so this is what we mean.
Epiphysis.
So physis, so this is what you get in patients up till they hit puberty. And once they've hit puberty, that turns, this basically becomes a physeal scar. Then it just looks like a very faint line after a while. Epiphysis closest to the joint, metaphysis is just soft bone close to the joint, but still, it's slightly farther away than the physis and epiphysis. And then you've got the diaphysis, which is where the bone becomes a tube. So the only reason on the X-ray you see thickening of the bone both laterally and medially is because it's an AP view. When you look at it in a cross section in a CT scan, you'll essentially see just a round circular bone with hollow bone in the middle. And that's when we talk about the Salter-Harris classification. When you are towards the end of your medical school time, it's not entirely unreasonable for people to give you an X-ray of a skeletally immature patient and get you to talk about the Salter-Harris classification, or talking about where the fracture line is in relation to the physis. So this is, if you're looking at the ankle upside down, or let's imagine this is a wrist joint, and you've got the epiphysis, physis, and metaphysis. So Salter-Harris 1 is where you've got distraction at the level of the physis. Salter-Harris 2, where you've got a fracture line below the level of the physis, and the fracture extends into the physis. 3 is the opposite of that. 4 is through and through, and 5 is a crush injury through the physis. All right. So somebody told me about mnemonic not quite long ago. I think the mnemonic is called SALT. I think S, I'm not sure what it stands for. A means above. L something to do with away. T through. And I don't know what this meant. So yeah, I'm not very good with mnemonic. But essentially, one's below the level of physis, one's above it, one's through it.
I think I've seen it before as S being for slipped. Does that make sense?
Yeah,
Wasn't S
yeah.
straight or straight across?
I think S is probably straight across. I think if
Yeah.
something slips, then
Straight
that's
above,
it, that's
lower.
gonna do it. But,
Through and then round or round is the last one.
Good stuff. Right. So getting some knowledge from the audience. That's we like that. So if anybody has clever ideas, please do unmute yourself. Thank you very much. I think I've got a question come up in chat. Oh, is there no fracture of the fibula? It's a growth plate. Yes, I think Mujia asked me that question, so let's go back to that. So yeah, so that is not a fracture. Okay, that's just you know, that's your physis. I think actually I would personally revise my answer there. I think actually, Wajiha, you are right. There is possibly a fracture there. And the only reason I say that is if you look at a normal X-ray, you will see that the physis is essentially the same width throughout. So the type of the ankle injury that is where your ankle has inverted. The physis here seems a bit more wider, and here a lot less wider, and that basically is equivalent to a pull-off injury of the lateral aspect. So if you twist your ankle, your fibula will be distracted, and that's essentially what's happened. So this is what we would call a Salter-Harris 1, and we can't really appreciate it very well, but Wajia, you seem to have very good eyes. Any clarification on this? Because Salter-Harris is very, very important. I'd assume everyone's happy. I'll move on. Okay, we won't spend any further time on ankle fractures because we need to get to more things, but this is how we fix something that has a medial malleolar fracture. We put screws through it, and a fibular fracture above the level of syndesmosis that's been fixed with some screws and plates, and where we assume that the syndesmosis is disrupted because it's above the level of the syndesmosis. Then we put a massive screw throughout the fibula into the tibia to stabilize the syndesmosis. In cases where you don't think the syndesmosis is disrupted, you leave the syndesmosis well alone. But we'll talk about this in more detail when we talk about fracture management. And this is what.
Sorry.
Yep.
I just wanted to ask what the difference was between the Salter-Harris 1 and the Salter-Harris 5, because they look quite similar.
Yeah, so the difference to tell on an X-ray is very difficult. Majority of people will not really be able to an X-ray tell whether it's a 1 or a 5. But generally speaking, 1 is where you get a slip, or whether you just get a straight through fracture that's very low energy. But if somebody has a crush element to the fracture, where you've got like a fracture line going all the way across very close to the physis, and they have, let's say, fallen from height, then although you may not be able to appreciate much on the X-ray, they would get this injury that you'd only really be able to see on an MRI scan. And the ramifications are that if you have a Salter-Harris 5, which is a crush fracture, the rates of growth arrest are nearly 100%. By that, I mean that a patient that'll have a Salter-Harris 5 fracture of the right wrist as opposed to the left will experience growth arrest before the age of menarche or puberty, and their wrist will stop growing. And back in the day, we'd only find out that this was the case once they stopped growing, and they'll all talk about a history of injury. So that's rather historical. Salter-Harris 1 is where you can actually see clear evidence of a slip of the physis, but it doesn't really have a massive impact element to it. So it hasn't gone thump and and you've missed it. Majority of the times you'll be able to find Salter-Harris 1, as one of my colleagues just pointed out over the audience chat, that actually the salt part of the mnemonic S means a slip or straight through. Those are low energy injuries, and as long as you actually put that top bit, this bit back on top of it, you will continue to grow. So 1 to 5 also talks about the severity of the injury and whether you're likely to get growth arrest or not. Is that clear?
Yeah, thank you.
Cool. Any other questions before I move on? Right, okay, fine. So this is just a picture to show, I mean, you're never going to get an x-ray like this, but when you go to work in major trauma centers that do your placements there, you'll see people with pure dislocations of the ankle, where both the medial and lateral malleolus is gone and the rest of the foot is just pointing in the wrong way. And we do tend to sometimes stabilize by putting pins on the outside and connecting them with a rod. And those are called external fixation. So this is really the meaty part of today's topic, and this is essentially what you're definitely expected to know by your finals. So yeah, I think I need one volunteer who can tell me about both these x-rays in one go, so we can swiftly move through this topic. Any volunteer?
Hi, my name is Mina. Is this a neck of fracture? I can't say the word. NOF fracture.
Yeah. So what do you think NOF stands for?
Neck of femur.
Yeah. So it's a neck of femur fracture. Are you talking about the right or left?
I am talking about
Left.
So this is an anterior posterior image of. Are we okay? I actually I noticed it on the right side image. There's like a crack between the ball and joint.
Oh yeah,
This
the
one?
right.
No, the other side.
That one. Okay.
Yeah.
Fine. So let's go on to your left side of the screen first. Okay. I know you got a bit excited about the diagnosis, right? So what view is this, and what joint is it?
So this is an anterior view of the hip and pelvis. Sorry, pelvis and femur joint.
Right side, yeah.
Right-sided, yes.
Yeah. Okay. And what's the? You said it's a neck of femur fracture, yeah.
Yeah, I can see a fracture that is. Yeah, I don't know how to describe it, to be honest, but it's you're pointing there.
Would you say it's intracapsular or extracapsular?
Oh, intra.
This is an intracapsular.
Yeah. Okay. I'll give you that. Okay. And then, so this is essentially a substandard view. So whenever you're looking at hip fractures, you need to get a view something like that, where you can see both iliac wings, a bit of the sacroiliac joint, and both femurs. Okay. So this is the reason I showed you this, is because whenever you get given this, just ask for an entire AP pelvis and both hips. That's the name of the view you're looking for. So you don't want just an x-ray like that. You want an AP pelvis and both hips, and you also want lateral. But you've done really well there, so we'll carry on with you. So on the left-hand side, you can't quite see the fracture, but can you agree that there's something going on here, where the hip just looks very, very different compared to this side?
Yes.
Okay.
It's lifted almost.
And what are the things that you can see on here that make you think it looks very different, this part?
I've
Well,
lost
it looks
that,
like the femur joint. There's
yeah.
like a split in the middle. Where
So
the
it's
more,
connection.
Anything else?
I can see that the ischial spine. Yeah, this area, like it looks, the obturated foramen looks smaller than the other side.
So normally when that happens, that's because of the fact that the pelvis is rotated. So that's not an abnormality within the pelvis itself. That's because when you put the X-ray beam is gone at a slight angle than the true AP. So that's a slightly rotated view. But the thing that I'm still trying to get you to say is that, so you see, this is the greater trochanter, that's the lesser trochanter. Yeah. So the lesser trochanter normally always sits at the back, but when you start to see more of the lesser trochanter, you know that the hip has become externally rotated. And because the greater trochanter is moved up, we can say that this femur is shortened and externally rotated, and that the only way we can tell that is this level is obviously a lot higher than that level, and secondly, we can see more of the lesser tuberosity. So whenever you see that, you know it's shortened and externally rotated. And those of you that have spent any time in a
External
geriatric ward or in orthopedics will know
rotation.
that whenever we talk about intracapsular
That's
hip fractures, we always talk about patient has presented with a painful hip which is shorter than externally rotated. And that normally just slips through the tongue without realizing that it actually shows on the x-ray as well.
visible.
So that's a very important bit that you guys want to know about. And whenever you guys do your orthopedic rotations, consultants that are interested in teaching you orthopedics will put you on the spot and will ask you about it. Okay, good.
Thank you.
So whenever looking at x-rays, again, get AP pelvis, both hips, get a lateral view. And things that are always telltale signs, we talk about the greater trochanter and the lesser trochanter. You should only really see a peekaboo lesser trochanter. You shouldn't see more than that. As here, you just see a massive chunk of it. That's a normal. Again, another picture taken from Radiopedia. And then people like to talk about Shenton's line. It's a very much an undergraduate orthopedic thing, Shenton's line. So you need to know about it. So if you draw a line from the inferior part of the femoral neck and you draw it up to the most medial part of the femoral neck, that should be then in line with the superior pubic ramus, and that should all be continuous. So if you look at the previous x-ray, if you draw a line from here starting all the way, then this is a very congruent line and there's no disruption to it. Whilst if you draw a line here, all of a sudden when we get to that point we have no idea what's happening, and that certainly does not all line up. Okay, so is that clear to everyone how this line works?
Yeah.
I assume yes. And then other things that you can see for completely undisplaced fractures of the femoral neck, you may just be able to see a line. Okay, the line could be oblique or it could be more straight. Or sometimes you can see a line between the greater trochanter going all the way to the lesser trochanter. Those are the ones that are called intratrochanteric fractures. And then this is essentially the basis of the Gardens classification. Again, very, very, very sort of favorite topic at the undergraduate level. Garden classified the intracapsular neck of femur fractures. And by that I mean that the hip capsule ends at a line just proximal to the intertrochanteric line. So if you draw a line between the greater trochanter and the lesser trochanter, if you get a fracture at that point, all of a sudden that is an extracapsular fracture because the capsule actually ends somewhere here. So the fracture line, if it's here, that's when the Gardens classification actually becomes relevant. So the Gardens classification does not describe extracapsular fractures. And I like to think that it's clear to everyone. So as you can see on this picture, all the fracture lines are at a level proximal to the intertrochanteric line. So by nature, they're all intracapsular neck-of-femur femur fractures. And then A, B, C, and D is based on the degree of displacement. So 1 tends to be completely undisplaced. 2 is minimally displaced. 3 is where you clearly can see it's displaced but not completely offended. And 4 is when you can see that the two ends of the bone are sat in different postcodes. And that is essentially the summary of what this classification is. And essentially the reason why this is done is the risk of avascular necrosis, which is a fancy term for us talking about the death of the bone. Okay, earlier I was talking about where the capsule ends. So this is where the capsule is, and any fractures within that would be called intracapsular. And then intertrochanteric here. And then there's another word called subtrochanteric. So if you see a fracture at this point, it's no longer in part of the line between the trochanters, then it becomes a subtrochanteric fracture. And then the popular topic of the blood supply to the femoral head. So I think at your level, you'd be expected to know that the blood supply to the femoral head comes from the femoral artery, but you won't be asked to name the actual branches. And because of this sort of tenuous blood supply, whenever you get a displaced neck-or-femur fracture, there is a risk that this blood supply was disrupted due to the shear forces applied through these very tiny blood vessels. This isn't the case when the fracture tends to occur outside this. And this is why whenever people get these fractures within the capsule that are displaced, we tend to prefer replacing the fracture rather than try fixing it. Because if you try fixing the femoral head onto the rest of the femur, although you've done a great job, but if you don't have good blood supply, that bit of the bone is just going to die away, in which case you end up having to redo that surgery, and that's not what you need. This is a normal AP and lateral of the hip, so lots of people become really good at looking at the AP, but it's the lateral that people struggle with. And lateral is just essentially, looking at the hip from here, so the X-ray beam is coming this way, and you can end up seeing the front of the head, the front of the neck, front of the femur, back of the head, back of the neck, back of the femur. That's the front of the trochanter, that's the back of the trochanter, and the lesser trochanter is somewhere around there.
True enough.
Okay, so these are your lines. Don't worry about the fancy lines here. This is more postgraduate. This is the line of interest for you. So this is a superior pivot the center line moving this way. And this would be your lateral view of your hip, as we talked about just now. Okay, now I would like to have a volunteer for this. Please, when you guys start talking about the X-rays, just don't jump into talking about the diagnosis. I still want you guys to say these things. I still want you guys to talk about the view. I still want to know whether you want a lateral or not, whether you want a better view or not, and then go to the diagnosis.
Overexposed. Overexposed.
Awkward.
Underexposed.
Am I still connected?
I can have a go.
Yeah, thank you.
So this is Dorothy Saunders, who's 80 years old, and that's her date of birth. This is an AP view of the right hip. Is this an extracapsular fracture?
Yes, it is
As
an
the Shenton's line is disrupted.
Yeah. Would you like to get a better?
I would like a lateral view.
Externally rotated.
Yeah. Okay. So I think you're spot on. What made you think it's extracapsular?
It's not in the neck of the.
Yeah, and the sub
Yeah, simple as that.
something.
Yeah. I mean, you can see the entirety of the neck at the top and the bottom intact. So I think, if you're a gambling person, when you see the top of the neck and the bottom of the neck this long, for a fact that's not intracapsular. So well done. So this would be an intratrochanteric if you want to be very, very descriptive. But if you just say it's an extracapsular neck of femur fracture, you will be on the money. Well done. Thank you for volunteering. Oh, by the way, I didn't realize that I didn't put 2020. This is not her date of birth. This is actually the date it was taken. But this is my own shortcoming there. So always write 2020 and not just 20, because this can happen. Okay, so extracapsular neck of femur fractures, because the blood supply is still intact, you can fix it with a variety of techniques. You can either use a short intramedullary rod to fix it, or you can use a DHS. And, whichever you like to do, you can do. We can talk about the specifics of each one another day, but I think the main thing is these ones you can fix. You can fix using different fixation techniques. But you don't do hip replacements for these. Okay, so this is what a short intramedullary rod looks like. Somebody else told me about this in the X-ray earlier, but I want somebody else to volunteer and go through the exact same thing, so you guys get used to doing this over and over again. Those of you that are not volunteering, at least in your own head, talk about the fracture. If you don't want to talk about it in your own head, have a piece of paper, pen, just
Intracapsular
write down exactly
fracture,
what's
externally
that in the exact same
rotated.
algorithm.
This is Joe,
Volunteer, please.
80-year-old. I was taken on
So
the
this
31st
is
of
Joanne
December.
Biggs. She's 80 years old, and this image was taken on this date. Do you have a lateral view?
I don't have a lateral view, and I don't have a full AP pelvis in both hips, so this is the view only given. Thank you.
Okay, so this is a AP view of sorry, the right hip, and this is a intracapsular. Is that right?
Yeah.
Intracapsular fracture of the head of femur.
Yeah.
And
And
it looks like
it
it's
would
being externally
be a
rotated.
Gardner classification 3.
Yeah, it's at the very least a 3. So well done on getting onto that. But it's Gardens. I think there's a Gardner classification for another.
Sorry.
No, I mean, I struggled with that even until recently. Say, garden classification, and you just have to remember in your head it's a garden, and you know, whichever way you like to remember it, do it.
Yeah.
But yeah, it's at least a garden 3, yeah.
And would you comment on the Shelton's line?
Yeah, so you can talk about the Shenton's line when you start
Shenton's.
talking about it in the beginning.
Connection.
So you can say that I can see that the Shenton's line is disrupted, and I can also see there's a fracture through the femoral neck. So it makes me think that this is an intracapsular neck of femur fracture.
Okay.
So that's how you can word it if you really, really want to show off. You want to say Shenton's line disrupted. I can see a fracture through the neck, both inferiorly and superiorly. I think there's displacement at the fracture site. I think this is an intracapsular neck of femur fracture. And with regards to Gardner's classification, I suspect it's a Garden 3.
And from this view, can you see that it's externally rotated, but you wouldn't know if it's shortened because you need the...
Yeah, so this is definitely externally rotated, and things normally can only externally rotate if they're shortened.
Okay.
And you can see that this part of the femoral neck should be sat here.
Yeah.
That's gone up superiorly like that is without a doubt, you know, shortened. But yes, you can say that. Again, that's just, you know, that's really the brownie points. But yeah, well done, thank you. Okay, so anybody want to comment on this X-ray actually? That would be quite useful. This X-ray can be given
Does she
to
have
you.
some kind of
And just say what you see. Like I said, here
what's
I'm
that thing
here
called?
to encourage you guys to talk about X-rays, not discourage and pick on you guys. So just go ahead. Anyone? Sid, I know you're one of the co-hosts. You can have a go, mate.
So this is an AP view of the bilateral hip joints. Exposure could be better.
Yeah.
There's a right hemiarthroplasty in place, in situ.
Yeah, and what's a hemiarthroplasty?
So a hemiarthroplasty is when you don't. So it's basically half a hip replacement. The acetabular component is not replaced.
Yeah, so what bits are replaced?
So just the neck and the head of the femur, and then you have a sort of metal socket going intramedullary.
Yeah, good. So, yeah, as Sid just mentioned, so the actual socket, the acetabulum is not replaced, and only the bits that are broken are replaced. So in the previous X-ray, so this bit is broken. So essentially, we know that the blood supply to this is going to be really, really poor. So we're not going to try fixing that. We're just going to make a cut here, fill the intramedullary canal with a bit of cement, put a stem there, and put a femoral head on on top of this stent and just get this patient walking as soon as possible. And that's a half a hip replacement. Sid, do you want to have a go at what this is?
Yeah, I can give this a go. So this is again a AP X-ray of the bilateral hip joints. Again, exposure could be better.
Yeah, so what you want to see the top of the iliac wing? Yes, perfect.
And this, I think, is a total hip replacement because you can see that in addition to all of the aspects of the hemiarthroplasty, there's also the acetabular component that's been replaced. So the metal bit is very much in situ there.
Yeah, good. So this happens in cases where you've got a hip fracture like this, and this hip fracture hasn't occurred in somebody who's 80 with a whole lot of medical problems. So if somebody is at the age of 60 and have come in with a fracture like this, and they are very much functional, drives a car, walks a long distance, then again, you wouldn't try to fix that because this will end up needing a second operation, in which case you, instead of doing half a hip replacement, you do a full hip replacement. And the reason for that is that patient at the age of 60 will be able to withstand a longer operation, a longer anesthetic time, and is likely to do better with this type of hip replacement. So whenever somebody has an intracapsular neck or femur fracture, if you're either physiologically old or you're not, and a patient that's physiologically really old and frail, they will have half a hip, and those that are physiologically, not really that old but really are over the age of 60 will most likely have a total hip replacement. I hope that's clear.
Can I ask a question?
Yes.
I was just wondering, is it normal for it to look so much smaller than?
Yeah, so the femoral head that goes on top of a total hip replacement is always significantly smaller than the one that goes on top of a hemiarthroplasty. So in hemiarthroplasty, you essentially replace the femoral head, you try to match it with the size of the other one. Okay? When you do a total hip replacement, because you're also resurfacing the inside part of the acetabulum, that has a thickness. And the thickness normally tends to have an outer diameter and an inner diameter. Due to the thickness of the inner diameter of the acetabular component, you can't really put a femoral head that's the same size as the other. So that's why the femoral head on on the total hip replacement just looks a lot smaller. Is that clear?
Yeah, thank you.
Good. Okay. So this, essentially, the reason I put this X-ray up there is this is what a perfect AP pelvis bilateral hip looks like. You can see the tops of the iliac wing of both. You can see outside the greater trochanter of both. And this is essentially a completely normal X-ray. Okay. So I didn't want anybody to be put on the spot talking about things that are abnormal here. I don't really want to know about bowel gases or anything like that, whether there's any stool, feces in the bowel. I'm an orthopedic surgeon. If I'm testing you about orthopedics, I'm not trying to catch you out. So you'd say this is, essentially a normal, well-taken X-ray of both hips. The X-ray I want to show you guys is this X-ray, and this is where I need a volunteer who is quite keen to talk about this X-ray because there's lots to talk about.
No idea.
And we're running out of time. We've only got 20 minutes and a few other things to cover.
Is that communicated?
I can give it a go.
Yes, please do.
So this is an AP view, bilateral of both hips, and on the right side, I mean, overall it looks like they have osteoarthritis, I think.
Yeah. And what image is that?
The loss of
Just
space
because it's so
between the
high.
joints.
Is it hypoechoic? Is that the right word?
Yes, but you're on the right lines. But yeah, just talk a bit more about what things are there that make you think it's osteoarthritic.
So the because it's white around the head of the
Yeah, do you know what
actual-
that whiteness is also known as?
Osteophytes.
No.
Called
Osteophytes.
sclerosis. So whenever you get sclerosis,
Oh, it's opposite.
and more specifically subchondral sclerosis, subchondral means just near the
Okay.
chondral surface. Chondral surface is where the joints are. So when you get subchondral sclerosis, that's one telltale sign that you've got arthritis. You use the word hyperostoic or something like that. Essentially, you're looking for osteophytes. Osteophytes
Oh.
are extra bony growth formations that tend to occur
So,
around an arthritic hip. That's the other telltale sign. Any other signs that you can tell us about?
osteosclerosis.
What for arthritis?
What is
or-
arthritis, generally speaking? When we try telling patients about what arthritis is, how do we dumb it down for them?
Arthritis. All the different types.
I don't know.
Rheumatoid,
Say the
osteoarthritis.
Yeah.
But when the joint is worn, essentially we talk about loss of joint space. Yeah.
Oh, okay.
Yeah, good. But yeah,
So
really
cute.
good attempt. Yes, no, perfect. You see, by the time you said it's an AP pelvis in both hips, and there's a normality of both
Oh
hips, and I
god,
think
I
it's
love it.
osteoarthritic.
Way more
You've
nerves
already
than
scored
I am.
maximum points. You know, you really are only talking about more things just to score the extra brownie points. You know, go from pass to distinction. So this is what we call osteophytes, so, additional bony growth that you get around the joint. That's the fancy term for it, osteophyte. So you get superlateral, inframedial osteophytes. You've
Superlateral,
got these little cysts. So if you
inframedial.
magnify that, you've got three little cysts
You
here.
say so.
They're called subchondral cysts, so cysts that sit underneath the joint surface. You get subchondral sclerosis where you've got that whiteness,
Subchondral sclerosis.
and you've got reduced joint space. And these are all your signs that you're looking at when you want to talk about arthritis. And there's a well-known mnemonic called LOSS. This is the mnemonic. So loss of joint space, osteophytes, subchondral cyst, subchondral sclerosis. So if you're not going to take away anything from today's lecture, as long as you can talk about three things: the syndesmosis, the intracapsular versus extracapsular necrophthalmia, and describing arthritis in terms of this mnemonic loss. As long as you take away these three things, I've still done my job. So please feel free to take a screenshot of this. Please don't record me. I really don't like being recorded. And we talked about the consent process earlier as well. But I'm more than happy for you guys to take a few shots here and there. Any questions on that? Because this is extremely important to know about loss.
Nope.
Assuming not. So this is essentially what a knee X-ray looks like in somebody who's skeletally immature. Okay, so again, you've got a physis here, you've got a physis there. So just to signpost, we've moved on to from hip fractures to knee. So you've got a femur, you've got your tibia,
Is
you've got your
person
fibula,
young?
and you've got your intercondylar eminence. This area is called the medial tibial plateau. This space is called the lateral tibial plateau. Medial femoral condyle, lateral femoral condyle. Okay,
Fibula
and
is
then
lateral.
epicondyles are here.
Epicondyle.
Sorry, I'm just going to pause there. I've just had a question pop up on the screen. How do you tell the difference between cyst and sclerosis? So cysts are these tiny lucent regions. So lucencies normally tend to be darker. So they look like bubbles. And that's what cysts are. So cysts are darker because they've got a higher water content. Sclerosis is where the joint surface gets whiter. And that's what sclerosis is. Sclerosis is hardening of the bone at the joint surface.
Oh, hardening.
Whilst cyst is just underneath that hardening. You've got some cysts that are full of synovial fluid. Is that clear? See? Happy?
What?
Good. Right, so moving on to the knee again. So this is a knee x-ray, and we've talked about how it's annotated. Do you really need to know about the medial epicondyle, lateral epicondyle? Not really. Just know that this is a medial femoral condyle, that's a lateral, because the lateral side is next to where the fibula is. And the tibial plateau medially here and laterally here. And the patella, you can just only see a shadow of it on the AP.
It's an anterior
Okay.
view.
Is everyone happy between the difference between a normal knee and an arthritic knee joint? I mean, you could argue that this isn't really a normal knee because you've got subchondral sclerosis, that increased whitening at the joint surface. So this is clearly somebody at the earlier process of their arthritis. So this is, again, a screenshot taken from Google. So unfortunately, whoever's done this probably doesn't know what they're talking about. But nevertheless, this is a bit more normal than this one. So you've got your osteophytes, you've got your subchondral sclerosis. Can't really see cysts there very clearly. Probably there are if you do an MRI, but you can't see them here. And you've got significantly reduced joint space. So you've got at least 3 out of the 4, and you can clearly say that this is an arthritic knee joint. Actually, you can see subchondral cysts there in the fibula, and that can also happen. And this is just that mnemonic again. Okay, so I'll give you a few giveaways here. This is the tibia, this is the fibula. Okay, and there's clearly a broken bone somewhere. You've got name, date of birth, and everything. So I want a volunteer who can go through this in the algorithm we've gone through over and over again. Okay, remember, with long bone fractures, we don't talk about intracapsular, extracapsular. So that's the added thing for the femoral head. So this is a bit simpler, so I want a volunteer to help me go through this. Anyone?
Transverse, comminuted, displaced.
Right, guys, no one wants to come forward. This is diagnosis. So
Comminuted,
you've
displaced,
got a tibia, fibula,
oblique,
and you've got fracture to both of them.
spiral,
And it's
distal,
displaced.
tibial.
Here, the
Transverse
displacement tends to be
posteriorly and
in
laterally.
the AP plane as well as the medial lateral plane. Okay, so we can see that you've got an oblique or spiral fracture. So again, if I'm a person that likes to gamble, I would say it's a spiral because normally these injuries occur due to twisting movement of the tibia and the fibula. You can see lots of little drizzle of bone, and normally when you get that, you know that you've got comminution at the fracture site, but mainly speaking, it's a 2-part fracture with comminution at the fracture site. Okay, this is an oblique fracture of both the tibia and the fibula. The fracture is angulated and translated. In the AP plane, you can see that the tibia has moved slightly laterally and slightly posteriorly in the lateral view. So you would say there's an AP lateral of Dolores Galaga, 40 years old, and the abnormality here is a broken or a fractured tibia and fibula, and then you go through these bits. And the other thing worth mentioning here, you've got what we call a back slab, and it's not a back slap, it's a back slab, and back slab is a plaster of Paris that only goes into 2/3 of the limb, and the reason for that is because you want to allow some space for the swelling generated from the bleeding at the fracture. You don't want to risk the compartment syndrome by putting a full cast straight away in an ongoing fracture. So given that I have described this, I want now somebody to talk to me about this, which is obviously a bit harder. So we'll start with the extra on the left hand
And it's
side.
come out. I forgot what that kind of fracture is called. This is obviously displaced.
I can give it a go. It's Tina. I don't have any patient details of when the X-ray was taken, but it's an X-ray of the right tibia and fibula. there is a midshaft fracture to the tibia and the fibula. I think it is, I want to say transverse, maybe.
Yeah, let's say it's
Or
transverse.
spiral.
With lateral displacement of the tibia and fibula.
So I'm assuming you're
I
talking
said
about this fracture, yeah?
medial.
Yeah. Oh yeah. Good. Nice little hint there. Also, I'd like to say that there is, proximal to that obvious fracture, there is also a oblique tibial fracture.
Yeah, so they're both going to be, generally speaking, spirals, because
Okay.
I think I think you have worked in orthopedics clearly.
Yeah.
Majority of the tibial fractures tend to be high energy injuries, and if they're high energy by nature, they will be spiral
Mhm.
nature as well. So the fracture's in two segments. What's the fancy name for that?
Compound.
If the fracture's in two segments, is a hint.
Segmental.
Yeah. Okay, so it's a
Mm.
segmental fracture to the tibia and a two-bar fracture to the fibula. And you
What
talked
word?
about the displacement perfectly. There's also another telltale sign there I want you to pick up and tell me about.
Is it an open fracture? Because it looks like
Open, yeah.
the tibia, that angle there is
Yeah.
invading. Yeah. There seems to be some gas or air in the.
Yeah. And would you say shortened as well?
Yeah.
Yeah, because you've got overlap between both ends of the tibia.
If you say it's shortened, do you also have to say that it's laterally displaced, or is the fact that it's shortened?
Yeah. You can
Okay.
talk about both. So things can be laterally translated as well as shortened. So when something laterally translates, because if you've got pull of the muscles, you can also get shortening.
Yeah.
Okay? Lateral and shortening. Okay, perfect. So those of you guys who are feeling bad about this, I think Tina works in the orthopedic department. So,
Also, I feel like I should say I'm a physio, so.
Yeah, exactly. There you go. So do still try to put yourself forward, because it's all learning. Once you put yourself forward and you go through things, you'll never forget things. So this is segmental fracture. Okay. Somebody just put on there, would that also be a comminuted fracture of the tibia? Technically, no. Technically, comminution is when we talk about this dust at the fracture site. Okay? When we talk about two large segments of bone, we don't use the word comminuted or multifragmentary, because we're not talking about fragments of bone, we're talking about big segments of bone. So with long bone fractures, if you see two fractures lying, they're all called segmental. There is no other word for them. And you want to talk about whether it's open, whether it's closed, and you want to talk about the associated fibular fractures, and you want to also request a lateral view of that as well. Okay. Given that Tina's had a go at this one, I want finally somebody else who have a go at this. Otherwise, we ask Tina or Sid to hijack the session again.
Can I ask a question about the one that Tina just did? Is
Yes.
there another fracture further up on the tibia? Or is
Yes.
that...
Yeah, so we talked. So that's what we were saying is you've got a fracture of the tibia at two different points, making it a segmental.
Why do you say
fracture.
displaced laterally and
You've
not
got fractures in
medially?
two different segments. No, that's all right.
And do you just say it's a complex fracture, or would you say it's a complex segmental spiral, or you don't need to say complex?
Complex in the old days was used to describe an open fracture. People used to use the word complex or compound fracture. And I think those terms are now out of date. We like to be quite clear in our words now. So it's an open injury where the tibia is poking through the skin. Okay? And we like to use the word segmental fracture because it's in two different segments. So whether it's complex or not complex is down to the skill of the surgeon, really, isn't it? So nothing's complex if you're a good surgeon, and everything's complex if you're a shit surgeon. So that's why nobody really uses those terms anymore. Is that clear?
Yeah. Thanks.
I need a volunteer for the next slide.
It's Alex. I don't mind giving it another go.
Hi, Alex. Okay.
I can't really see the sort of right-hand image because the text box is over it. So I'm just going off the leg in the middle, if that makes
Yeah,
sense.
so just go through the AP, yeah.
Yeah, just the AP. I can't see. So this is an AP X-ray of a left leg, and it's showing a mid-shaft tibia and tibial fracture. The tibia fracture appears to be a spiral fracture that is shortened and displaced medially.
Oh yeah,
And
it's
the fibular
so
fracture,
confused.
I would maybe comminuted. I'm not sure how I describe the fibula.
So tibia's gone laterally, isn't it?
Laterally.
Yeah.
Yeah. Oh yeah, because we're describing the bottom fragment. Sorry.
Yeah, perfect. So this is the best example of what a spiral fracture looks like. So there's an apex there, and it's a spiral in nature. So there's a spiral configuration going on. So this is the back of the spiral of the tibia, which is a distal fragment, and this is the proximal fragment. And oblique fracture would just be a straight oblique line, but this is a very nice example of it. But yeah, other than that, there was nothing else to pick on, Alex. Well done. If you want to be super descriptive, you can say that the fibular fracture is at a more proximal level than the tibia fracture, but that's just being pedantic. I think you would score very highly by just looking at this and describing it as it is. Okay, these are just some fixation options. So you can put a rod through the medulla, which is the bony canal formed by the tibia, and the fibula then tends to just knock back in place. Or you can do a massively long plate, both to the fibula and the tibia, especially for a fracture that was here. But yeah, we will talk about fracture treatments in a different lecture. Okay, so wrist fracture. So distal radius fractures. Again, they probably could be as common as neck-of-femur fractures in terms of the frequency as how they come up in the exam, or OSCEs or anything like that. So I'm not going to test you guys with regards to names of each bone.
Wow,
So
I
again,
love
this is
it.
another slide from Radiopedia.
Scaphoid
Very nice slides there. So do
C4.
go on to Radiopedia if you want to learn a bit of anatomy to go with radiology as well. But the bone of interest normally tends to be the radius, the ulnar, and the scaphoid. Sometimes maybe the lunate, but the lunate question would be very, very harsh. I don't expect that would ever come up in any of your exams. Okay, now given that I've already told you guys that this is the radius, this is the ulnar, you know that this is the scaphoid, you've got an AP, you've got a lateral. I think I've given most of it away. I need somebody, if not Tina, Alex, or anybody that's volunteered before, to please come forward. We're coming to the close, so it'd be nice to have new voices. Not that I don't like the voices I've already heard.
I don't mind going again.
Right.
I know you
Joe,
said
that's
no when
great.
you've heard. So this is an AP view of the right wrist, and there looks like to be a head of radial fracture. Is that what you'd call it?
So I'll give you a clue that the radial head normally tends to be at the elbow. Don't ask me why that is. It's just a really weird reason, and it's very
That makes
confusing
sense.
for students. So let's call
Proximal
this a
to you,
distal
to
radius.
your
And let's call
Okay,
this distal
sorry.
ulnar. No, this is nothing to be
So
sorry
a fracture at the distal radius,
Distal
Yeah.
end here.
and it would be an oblique fracture.
Yeah, I mean, it's not
Where?
entirely unreasonable. And what
No,
about,
she can't see
is it in the joint or not? So
No,
is it the joint?
no.
No. And fractures that are not in the joint, would you call them intra-articular or extra-articular?
So it's an extra articular, and there's no like shift in the. Would you still say that for the radius?
No,
There's
so that whole thing about Taylor shift is to do with the ankle.
Okay.
No other real joint has that kind of shift phenomenon. So
Okay.
radius, the main things to really talk about is the fracture mainly through the radius, or does it also involve the ulna? And whether the fracture is displaced or not, whether the fracture is angulated or not, and whether it goes into the joint or not.
Okay.
So those are the questions that you try to address when describing fractures of the radius.
Okay.
Okay. So one clue that I'll give you here, in this lateral view, normally this bone will continue to go like that, and there'll be anterior tilts like this. Okay. So what's happened here is this is a two-part distal radius fracture, but the fracture has angulated dorsally. So when we talk about radius, we talked about the dorsal side, which is the back of the hand, and the volar side, which is the front of the hand. So volar side is where your flexor tendons are, and the dorsal side is where your extensor tendons are. Okay, so we don't talk about it in the AP sense. All radius are talked about in dorsal and volar sort of terminologies. So given that Joe has done this very well, I need somebody else to kindly do this. If people don't come forward, I think I will continue to lose interest, and given that we well past our time, I'll be more than happy to call it a day.
Could I ask a question? I won't talk through that extra. The question is about the intracapsular and extracapsular of the wrist. I don't think I understand that.
No, so we don't. No. So we don't talk about intracapsular with the wrist.
Or
articular. We talk about intra-articular.
Yeah.
So you will see some fractures where a fracture line will be here, and also there will be another fracture line going into the joint.
Oh, okay. So that one is extra-articular.
Yeah. So this is extra-articular, and if you see a line going into the joint like that, that will become intra-articular.
Perfect. I think I thought you said that was intra-articular, and then I got confused.
No. This is extra-articular. If I've said if I've said the other way, then my apologies.
It was probably me. Thank you.
Okay. Anybody else?
I can have another go.
Dislocation.
Thank you. And that's
So this it has an anterior AP and lateral view of the wrist joint. There's a intra-articular fracture of the distal radius.
Why do you think it's intra-articular and not extra-articular?
I think I can convince myself that there's kind of a line that goes in, or am I making that up?
I mean, I agree with you, but there's a very complex reason why I agree with you, and the reason why that is because you see this joint between the radius and the ulna is called the DRUJ, or DIUJ, or distal radial ulnar joint, and this is also another joint. And if you get a fracture line going into that joint, technically it becomes an intra-articular fracture. So you are right for that reason.
Okay.
Yeah, but I definitely agree with you. Anything else?
And there is, if I look at the lateral view, the most distal portion is moving anteriorly.
Yeah, so what's that anterior part called?
Ventral displacement? Or?
Volar.
Volar displacement.
Yeah, volar displacement. Yeah, so it's definitely volarly angulated. Yeah. Anything to say here?
Is there a...
What's this bone called?
The ulna.
And what part of the ulna is this?
The distal end.
Distal part.
Distal, yeah.
Yeah, so it's a lot simpler. So would you say this is broken or not?
Yeah.
Yeah, okay. So you've got a distal radius and a distal ulnar fracture, yeah? And they're both displaced. And you've done really well, thank you. You should volunteer more frequently. Okay, fine. So I think this is just describing what we talked about. So whoever had a go at Keith Farrell's X-ray, essentially this is what we call a Colles fracture. This is an expected X-ray you should know about.
Displaced.
People will ask you what Colles fracture is. It is the most common injury sustained amongst women over the age of 50. The Colles fracture is when you've got a distal radius fracture which is angulated dorsally, and that is a definition of a Colles fracture. When something is angulated volarly, which is in here, where you've got a fracture of the distal radius where it's pointing anteriorly, or displaced anteriorly, or translated anteriorly, you've got what we call a Smith's fracture. Is everyone clear on that? So Smith's and Colles is something you are expected to know, and that's not because I said so because I'm an orthopedic surgeon, that's because that is just how it is. Any questions? Can you guys still hear me?
Yeah, we can hear you.
Okay, good. It's coming close to my baby's sleep time, so I was wondering if everybody else is sleeping. Right. Okay, so anybody who would like to have a go at this?
I don't mind giving it a go.
We've got Haseeb. Thank you, Haseeb. Go for it.
So this is the AP and lateral X-rays of John Hommans, 50-year-old. What we can see is a intra-articular fracture involving the radius. There seems to be some displacement of the radial styloid process, and otherwise,
the
I think there's
ulnar.
also one of the ulnar styloid process too.
Yeah, good. Yeah, that's really good. So the radial styloid is this prominence of the radius,
Styloid.
and the ulnar styloid is this little bit that's actually displaced here. So well done. I've got nothing else to add to that. So you talked about the name, the data was taken, and everything. You talked about the AP. Do you talk about the lateral?
Oh, I didn't mention any angulation, so I don't think so.
But what you can see is this. You can see that there's evidence of dorsal comminution, isn't it, or dorsal angulation. So that's just for extra points. But you talked about everything else. Yeah, don't ignore the ulnar, okay? Because the ulnar is a bit like the fibula. You can get things that are broken on that side as well. Well done otherwise. I think this is what normal angles of the distal radius and ulnar are. So normally you get a radial styloid that's a lot higher than the radial ulnar articulation, or the true distal radius ulnar joint, and that basically makes the radial inclination. And then normally if you draw a line between the radius and the ulnar styloid, that should be straight. And on the lateral view, the radius is tilted about 11 degrees at the front. So if things don't look like this normally, then you should be worried. This is different ways one can fix them. You can either leave it in a cast, or you can open it from the front and put a plate on it and a few screws, or you can not open it and just put some percutaneous wires. And if the fracture is in multiple pieces and there are no pieces that you can screw back or put a wire through, you can put a distracting external fixator on, which basically keeps the radius well aligned whilst it just allows the bone to come up. Again, we will talk about that one day. These are your eponymous fractures of the radius and ulnar, and that keep frequently coming up in the exams in all universities. So you should at least have a go at trying to go through this, and hopefully once you do it today, you will always remember it. So any volunteers again?
Let's see, that's displaced compound, segmental
I'll give a clue here for people
of
that are sort of
the radius
shy. So this bone is the radius, that's the ulnar,
of the ulnar,
that's the radial
radial
head,
head,
which is at the elbow
elbow,
joint,
yeah.
and this is the proximal ulnar, which is at the ulnar joint. So now, given that, can somebody please come forward? Okay, well, nobody wants to come forward, so this is a fracture of the ulnar at the ulnar shaft, and proximally there is a dislocation of the radial head. The radial head normally sits underneath the capitellum, which is part of the elbow around here. So when the ulnar has gone, the radial head is also completely come out of joint. So this is a fracture dislocation. Fracture is of the ulnar, and the dislocation is at the radial head or radial capitellar joint. Again, this is a very common question in all your MCQs. So one way I was taught how to remember it was Monteggi ulnar, which is just putting a word together, Monteggia and ulnar, Monteggi ulnar. And that means that ulnar is always broken, and whichever part is broken, the other part is dislocated. Okay? This is another mnemonic, MERG, which is Monteggia ulnar radial head gone. Have you guys ever heard of Monteggia fracture? Am I just talking at a slightly higher level than you guys expect?
I've never heard of it before, but it might be something we need to know.
I've never heard of it, but I'm only third year, so.
Yeah. So yeah, you will get to the point that you will have to learn about it. So why not be it today? And this is the opposite. So this is what a Galeazzi fracture is. So imagine here the ulnar is broken, there the radius will be broken, and the ulnar will be dislocated from the joint. Okay, so Monteggia is that, Galeazzi is this.
How do they present? Like, what would someone have done to get that?
They would have just purely broken an outstretched, they would have fallen on an outstretched arm, or they would have, for example, fallen and somebody else has fallen onto their forearm, creating weird forces onto their forearm.
Okay. Thanks.
Okay. So the other way to try remembering this is that when people normally break their forearm, so the radius and ulnar and the midshaft, they would normally break both bones at the same point. Okay? The reason for that is that the radius and ulnar have a joint proximally and distally.
Mm-hmm.
So at the elbow joint, they're also held. So the radial head and the ulnar are held by strong ligaments, and distally, they're also held by strong ligaments. Yeah. So it creates like a polo mint. So when this polo mint is created, if you break the polo mint at one place, another bit has to also break. So if the other bone hasn't broken, you would always have to worry that what's the reason for that? And that's when you have to go looking for a fracture, a dislocation at another part. Does that make sense?
Yeah.
Yeah, so just think about a polo mint, and that will basically help you determine that. Okay? Good, right, okay, moving forward. I think you guys can hear a bit of heckling that's happening outside my door, so that's actually my baby who wants to hang out with me before bedtime. So I think this is our last bit that we need to cover. So you've got your humerus. So your humerus is the bone that's most likened to your femur or the femoral head. So the humerus has a humeral head. It also has an anatomical neck. It has a greater tuberosity as well as a lesser tuberosity. In the femur, you've got trochanter versus lesser trochanter, whilst here you've got tuberosities. And then you've got the distal part of it. So the distal humerus is likened to a distal femur. Okay. Any volunteers for this, or I'm just going to skim past this now?
Yeah, I can go. This Joanne Bloggs, she's 60 years old, and this when the photo was taken. This is a AP of the right humerus, and
Head.
there is a head of humerus fracture, so an intra-articular fracture.
Okay. Yeah, that's good. That's good.
Is that right? Sorry.
I would just tweak. I would tweak it a little bit. The only thing to say, if you just said it is a right proximal humerus fracture of the humeral neck, which is
Humeral
displaced, I
neck.
think you would have been absolutely fine.
Humeral neck.
Okay.
So with this, if you see fracture line going into the humeral head, you would probably say it's an intra-articular fracture, but like, do you remember I said that humeral head is very similar to a femoral head?
Yeah.
So this bit
Because the joints are the same.
is called the surgical neck of the humerus. And the reason it's called the surgical neck is because the anatomical neck is normally here. But majority of the patients will actually break it at the humeral neck.
Okay.
All right? And this whole difference between surgical neck and humeral neck is because surgical neck is where the patient is most likely to break. Anatomical neck is what the anatomy dictates it to be. You can get anatomical neck fractures.
Is there one here?
No, this one is a surgical neck. I made a while ago. As I got older, I started to realize actually there's a fracture line going through here, and this so this part is actually called the greater tuberosity.
Mm-hmm.
Okay.
Yeah. If I was to now do this, I would divide this to a 3-part fracture. So one part is the humeral head. Line.
Wait.
And if you haven't got
It's
for the distal half of the shaft,
proximal.
yeah. Oh, well done. That's perfect. You know, there's nothing further to say.
Okay.
Okay. So this is called a scapular wire view when you're looking at the shoulder. So this is your AP view. When you're looking at a shoulder, you can also get a Y view where you're looking at the acromion, your scapula, and this is your blade of the scapula here. Okay, and your shoulder normally sits around here, so there should be a bit of an overlap. Okay, so this is just, again, annotations from Radiopedia. The reason I show this is a view that, so this is scapular wire view in which you can see whether the shoulder is dislocated anteriorly or not.
Mm-hmm.
So this is an X-ray just showing that the humeral head is no longer articulated with the glenoid. And this is a anterior dislocation because this part is all right?
Yeah. Thank you.
Yep, just 1 minute. Right, okay, so moving on, supracondylar fractures, you normally tend to have the most helpful view on the lateral. So the line going from the front of the humerus has to bisect the capitellum. That area is called the capitellum. and you've got the radius, and you've got your ulna here. And this is really the most telltale view. Majority of patients will have a normal anterior fat pad where you've got black sort of shadow in front of the humerus, and the tricep will be at the back. The pathology normally tends to be if you've got a posterior fat pad, so you've got blood at the back of the humerus, that's when you know you've got a problem, and the tricep is being pushed a bit more posteriorly. Majority of the time, the exercise that will be given to you, you should be able to pick out that there is a fracture that's displaced. This is only if there isn't a displaced fracture. So whenever you get supracondylar fracture in children, that's what tends to happen most commonly in children. This isn't really an adult problem. Then you get three types of fracture. One that's completely undisplaced, and that's when you can see blood at the front and the back. One which is displaced or angulated posteriorly, but the posterior side of the bone, the periosteal hinge of the periosteum is still intact. And you can tell that anterior humeral line no longer bisects the capitellum. And that's the second worst type of fracture. And this, we can all see that the two parts of the fractures are set in different territories. Okay, this is the basis of Gartland classification. You will never be expected to know about Gartland classification. This classification only comes into place when you graduate from med school and you're working in orthopedic wards or doing on calls. But it's just an easier way to try remembering that these are three ways a supracondylar fracture can break. Some people call it distal humerus because they're not experienced, but when you are experienced, you can say it's a distal humerus supracondylar fracture of a skeletally immature patient.
Skeletally immature.
So I have helpfully drawn the lines for you guys. I need volunteers. I'm going to only be next 3 more minutes, and then I'm going to go.
Do what?
Anyone? Okay, so this is an undisplaced fracture. So this is a Gartland A-type fracture. So you can just see there's a posterior fat pad here, which shouldn't be there, but the fracture is otherwise undisplaced. This is a completely displaced supracondylar humeral fracture. Okay, we talked about the Salter-Harris classification, and we'll cover all this stuff another day. So essentially, there's no substitute for learning basic anatomy, but as long as you can go through the algorithm of talking about the patient, the data was taken, the view, the fact that you need a lateral view, talk about what bones you're looking at, look at the abnormality, talk about the fracture, whether it's displaced or undisplaced, you are golden. Any more questions? I am going to conclude the session here.
Proximal distal, undisplaced. What's the difference between dislocation and displaced?
No questions. Thank you.
That's fine. Are you guys happy for me to send you some feedback forms? I'm hoping that you guys will fill them in.
Yep, that was really good.
Yeah, definitely.
Yeah, thank you.
And just before I go, I do need some honest feedback. Is this level well above and beyond what you expected today? Or you think this is something that you guys can absorb?
This was really, really helpful. I think it put everything together really nicely.
Good, good. Well, we will be running a lecture series, and we will go through fracture management. We'll go through examination of hip and knee, shoulder, spine, basic, your MSK screening, history, and things like that. So there will be 4 or 5 sessions coming this month or next month. So feel free to rejoin. And thank you very much for being a good audience. Unfortunately, we did have a few people that were recurrent volunteers. Hopefully next time less people will be shy. Well done, everyone. Thank you.
Classic.
Bye.
Thank you.
Thank you so much.
Okay, bye.